with his attorneys, and the prosecutors are present as well. You ready for the jury?
Yes, sir.
Okay, let's bring him in, please. Please be seated, everyone. The record should reflect the jury's back in the courtroom. Good afternoon, members of the jury. Welcome back. Hope everyone had a good lunch. Mr. King, do you want to proceed with the rest of your direct examination of Dr. Manguso?
Yes, please.
And Dr. Manguso, I remind you that you're still under oath.
Yes, Your Honor.
Good afternoon, Doctor.
Good afternoon, Mr. King.
I think when we finished up, we'd gone through all the instruments that you'd administer and the specific findings that you made as a result of those instruments. Is there any that you can think of that I missed that you administered?
I think we covered all of them.
Okay, good. What I want to talk about now a little bit is the clinical interview that you and Dr. Gray engaged in with Mr. Holmes, if I may.
Of course.
First of all, do you do an assessment of how, did you do an assessment of how Mr. Holmes presented to you when you encountered him in the form of like a mental status report or something along those lines?
Yes, along those lines, how he presented to us at the time of testing.
What's the purpose of doing that?
Well, it puts our test results in context. It helps us understand how a person is functioning clinically at the time of all the testing, and that's important.
Okay. And what did you note in your, if you need to take a look at your report, please feel free. I think it's on page 4.
Thank you.
What did you note about Mr. Holmes when you first talked to him during this process?
First, we noted his physical appearance. He was of average, he was a well-nourished white man of average stature. He looked a little younger than age 25. He was wearing, institutional uniform was the green institutional issued jumpsuit. He had a beard and curly hair. It was kind of unruly. We noted that.
Now, is grooming important?
It is.
Why?
Well, sometimes when people are in the midst of an acute psychotic episode, their grooming declines markedly. They oftentimes refuse to bathe. They certainly aren't attentive to, minor personal hygiene issues like, attentive to brushing their teeth or combing their hair. They become inattentive to all of those things.
Now, you said that's often the case. Is that always the case?
Not always, no.
Is the fact that someone is able to groom themselves mean that they're not psychotic or mentally ill necessarily?
Of course not, no.
What else did you note about him? How was the way he talked, his speech? What did you notice about that?
His speech, he was able to speak normally in the sense that the rate of his speech, how quickly he spoke, was normal. The tone was normal. The volume was normal. He wasn't shouting or whispering. He appeared to be fluent in the sense that he could come up with words that he wanted to use. And he was able to be readily understood.
Okay.
So we didn't find any behavioral indications of aphasia or, language deficits. We could understand us.
What's aphasia?
Aphasia is a language deficit.
What's a language deficit?
Okay, so I can't, it's not just like a speech deficit where I can't articulate the words, I can't pronounce them properly. If it's a receptive language deficit, it's like I can't understand what is said to me. If it's an expressive language deficit, I cannot produce the words I need to express my thoughts. And he didn't display clinically those signs.
Okay. How about his, the way he related to you or communicated to you? I don't know what to call that.
We would call it his interpersonal manner.
Okay.
It was initially pretty distant and reserved. Throughout our whole assessment, or certainly my time with him, I can't speak for all of Dr. Gray's, but I don't think it was different. He spoke minimally, generally spoke only to answer direct questions. He didn't elaborate on his answers. We often, if we had a question, we had to do a follow-up, and then a lot of times we would just get a minimal response from him.
What impression did that make on you, if any? Was that significant psychologically or neuropsychologically to you?
Well, when people are, it was significant certainly in one way. He certainly wasn't overplaying his hand. We have people who come in and they want to tell you all about what their troubles are and go on and elaborate at great length. He wasn't like that at all, so I felt as though he were holding back to some degree, talking about what was wrong with him or not.
Can that be normal for people who are mentally ill, that they would hold back some?
In my experience as a forensic evaluator, yes, that can be normal, because for anyone in a forensic evaluation, because it's awkward for them. Just the situation. Here they are sent down to see us at the hospital by the court, and we're asking many personal questions that can make anyone uncomfortable. It's a situation that many people get a bit withdrawn about. But he exceeded that. He was not conversational at all. And Dr. Gray and I usually, we've worked in the field for quite a while, so we do our best and are often successful at setting people at ease to the best of our ability. And we can usually talk with most folks, and we had a difficult time eliciting a lot of conversation from Mr. Holmes. He spoke minimally.
So you said that that's something that can occur situationally because of the situation that's going on. Was it your opinion at that point that it was that interpersonal manner was based on the situation, or that there was something else going on?
I thought there was something else going on.
Could that in part have been the effect of the medication?
Could have been, or, again, underlying mental illness factors with a combination of personality. I can't tease that out. I can just say what I saw.
Right, and understanding, you can't tell what it exactly was based on your contact, is that right?
No, I cannot.
Are you familiar with negative symptoms of various schizophrenia spectrum disorders, for example?
I am.
And could these have been a reflection of those negative symptoms of the disorder?
That's possible.
Was he cooperative with you? I mean, was he difficult? Or?
He was not difficult. He willingly completed every testing task I asked of him. He was cooperative.
Okay. Did he demonstrate any propensity to exaggerate or embellish his symptoms or problems that you noticed?
Not at all, no.
How did you discuss his mood with him? And by his mood, I mean his mood at the time you talked to him.
We did. We asked how he was feeling. What was his mood? And he just described his mood as slightly depressed, all right, which was, I thought, an interesting way to describe one's mood in the situation he found himself in, right? A very, very serious situation, the most serious situation of all legally that anyone can face. He just said he was slightly depressed. But he talked about other symptoms that appeared to reflect possibly symptoms of depression. Since being incarcerated, he's gained 30 pounds. He'd sleep all day if allowed to do so. Now, I would note that having worked over the years with many people who are incarcerated, that a lot of times people get bored and they sleep a lot and they gain weight. That can just happen. But it was also noteworthy for potential depression.
Okay. Anything else?
He said he'd had recurrent thoughts of suicide.
Okay.
We asked him how. Of course, that's a big issue for us at the hospital. We always have to assess people's suicide potential. We need to keep them safe while they are under our custody. And he denied that he had any imminent plan to harm himself. He did say he had recurrent thoughts of strangulation with sheets, but he realized that it was not a practical thing to implement because he was being watched 24/7 by nursing staff the whole time he was with us.
That he had recurring thoughts of that?
Yes, he had
I'm sorry, go ahead.
Oh, no, he just had recurring thoughts of suicide, and we said, did you think about a plan how you do it? And he said he didn't plan to do it, but he thought of strangulation by sheets. Okay.
Yes. Yes. Council, approach one more time, please, for clarification. I'm sorry. All right, members of the jury, I want to give you an instruction that I have given you before in this trial, and that is that the court has admitted the testimony of Dr. Manguso only for a limited purpose. You may consider her testimony only as to the issues raised by the defendant's plea of not guilty by reason of insanity. You shall not consider this evidence for any other purpose. All right, Mr. King, you may proceed.
Make sure I'm on here. Did he describe to you any symptoms consistent with what you would perceive as mania?
No, he did not. We inquired about that, and we found nothing that would indicate mania.
Okay. And I don't want to reiterate something that's already been said, but did you drill down on any of these areas, to use a colloquial phrase? Did you push him on any of these areas or ask questions over again or explore areas fully, or did you just kind of cover them in a cursory way?
Well, I would say it was more than cursory, but it certainly wasn't drilling down. The purpose was to establish rapport and conduct a basic introductory clinical interview so that we could see what his mental status was when we were doing his testing. We weren't attempting to do a thorough interview that would cover every aspect of his mentation. That was Dr. Metzner's job, not our job.
Okay. So you weren't trying to explore all of the various evidence that might be relevant, anything that might be relevant to his mental state or his diagnosis, were you?
No, doing all those things would be beyond our role in this case, which was quite limited.
So let me ask you some specific questions about that before we get into the questions that you did ask and the statements that he made. Did you talk to him about his relationship with his family or his friends or his girlfriend or his classmates or his professors in graduate school or anything like that?
The only two we touched on were his family and his girlfriend, and that in just a limited manner.
Okay. You already said that you didn't go through his notebook with him, right?
Correct.
Did you go through and talk about emails that he sent or Gmails or search terms or computer usage or habits or any of that stuff?
No, again, that was beyond our scope.
Okay. Did you deliberately kind of avoid the period of time immediately preceding July 20th, 2012 and including July 20th, 2012?
Yes, we deliberately left that for Dr. Metzner to evaluate.
That being said, did he describe what his mood had generally been while he was in graduate school?
Yes, and let me refer to my report because I remember addressing that. He said he was, quote, stuck in a low rut, unquote, since beginning graduate school.
Were you able to check whether he was oriented times 3? I'm learning all
Yes.
these new terms.
Yeah, okay. Yes, we did. And he was.
And was he able to correctly, did you know who he was?
He knew who he was.
He knew where he was?
Yes, he did.
Did he know what the date and time was?
Yes, he did.
Okay.
But yeah, let me just correct that just to be completely accurate. He was off by 1 on the date of the month, but he self-corrected easily with a minimal cue. That's not at all uncommon when people are hospitalized. They might get mixed up if it's the 17th or the 18th or what have you. But I would describe him as oriented to time.
Okay. Would you describe his thought process to the extent that you were able to observe it or comment on it as being linear and coherent and logical as far as you could tell?
Logical and coherent. Yes, he was.
He didn't make any statements that just didn't make any sense at all to you or that seemed extremely disorganized in a psychotic kind of way?
No, he didn't do any of those things during our time together.
And you've experienced psychotic individuals who demonstrate psychotic symptoms, have you not?
Many times.
How many?
Oh, I can't even count. It's a part of my work at the hospital. I see mentally ill people.
Do you deal with those folks every day?
Every day I'm at work, just about.
Did he appear to have a fairly intact memory in terms of, just general events that happened in his childhood and throughout his life?
Yes, again, we didn't talk about many, many, many details. The things we did talk about with him were consistent with what was in his record.
Did you talk to him a little bit about his childhood and his family and things
Yes,
like that?
just basic information, correct?
What's the point of doing that?
Well, on many fronts, first of all, you want to check someone's memory for remote events. Second, we wanted to hear from his perspective what his childhood was like, what kinds of activities he would be able to respond to and tell us about. It's just basically, again, general background information so we understand who we're dealing with when we test him.
Gotcha. Did you talk very briefly about prior treatment that he may have received, both when he was a little child and by Drs. Fenton and Feinstein?
We did.
Okay. How in depth did you get into that?
Just the basics. We didn't talk about a lot of the details about, for example, his treatment with Dr. Fenton. We left that for Dr. Metzner.
Okay. Did you limit it to Did you go see Dr. Fenton and the medications that he was prescribed, essentially?
Why did you go to seek treatment? What kind of problems were you having? What did they do for you? Those kinds of questions.
And what reason did he give for going to see them?
I believe he was anxiety, and let me see if that is, if my recall is correct by checking my report. Yeah, I think we put in here just mental health concerns, but as I recall, he was telling us he was anxious. And I think this is something I read when my review of records, not that I recall myself, but I thought it was something to do with a fear of public speaking or anxiety about some aspect of that.
Okay. How about like alcohol use and drug use?
That wasn't an issue. We took a reasonably thorough history, and we didn't find anything that would indicate any severe substance abuse problem.
Okay. Did you ask about hallucinations?
And we did.
And what did you learn about that?
Well, we learned a few things. First of all, when we asked him, was he hearing voices or had he heard voices? And we asked these questions both now and then before you started the Risperdal. And we were Risperdal being the antipsychotic medication. And when we talked about that time frame, we were talking about right before he started it. We weren't talking about, the events of July, right,
Okay.
of 2012. So he told us that he wasn't hearing voices and hadn't been hearing voices, but then when Dr. Gray was looking at some of his test results, there was an item that raised a question for him about that. And so when we met with Mr. Holmes in follow-up on the last day of our time together, the 15th of August, I think Dr. Gray asked him just about that. Said you told us you weren't hearing voices, but some of your test responses indicate that maybe that wasn't true, or maybe you responded in another way. Can you tell us about that? And then he indicated that before he started the Risperdal, like in November of 2012, we're talking now, he had been hearing voices, he said.
Okay. So, and maybe you said this and I didn't hear it correctly, but were you asking about whether for his entire life he'd ever heard voices or had hallucinations, or were you just asking about the period of time since his incarceration?
We were talking generally about since his incarceration.
And what did you make of that? That he denies experiencing hallucinations, but then something comes up in the test and you ask him about it and he says, I did experience auditory hallucinations.
Well, again, to me, and in my clinical impression in working with him, was he was holding back and not talking about some of his symptoms. I mean, he wasn't one of these people who comes in and says, again, let me tell you what's wrong with me, doc. I want to go through my list of problems to be sure you get it down right so you can write it in your report. It was the opposite. He would respond very minimally, and I think was underreporting some of his issues.
Okay, so not necessarily saying all of the symptoms that he may have been experiencing.
That was my clinical impression, just because he was reticent in general.
Now, did you ask him about thought content consistent with a delusion?
We did.
And I think we know what a delusion is now, fixed false belief, is that right?
That's right.
Did you ask him about any delusions that might be contained in the notebook or that happened before July 20th, 2012?
No, we focused on the more recent time frame, from November of 2012 approximately, up into and including the present time.
Did he report any thought content consistent with delusions in your opinion?
Yeah, there were a few things. May I refer to my report?
Yes, ma'am.
Okay, what he told us was this, that before starting treatment with the Risperdal, and again, we're referring to that immediate period right before, he thought that the television was broadcasting special messages meant only for him, although he doesn't recall the content, and that his thoughts were being broadcast outside his head so that others could read his mind. He stated that after starting the medication, he no longer believed those things to be true. He said that both at the time we saw him as well as prior to his time of treatment with Risperdal, he did not believe he had special powers or that any entity was trying to plant ideas in his mind against his will. He denied, both previous to the Risperdal and when we saw him, that he denied that he thought he was being persecuted or that he had a special mission in life that others did not understand.
Now, I noticed that in your despite the fact that your handwriting consistent with other doctors seems to be difficult to read.
I'm sorry.
Do you go through a kind of a form as you ask these? Is that a form that you created to help you?
It's a form actually Dr. Gray created, and we've all modified it over the years. We find it to be a helpful mental status examination form at the hospital.
So these kind of questions, special powers and entity trying to plant ideas in your mind, are those kind of items that you have on your little form there?
Right, and it's not meant to be like a grocery checklist when you're interviewing someone, because people don't necessarily want to talk about things in order. You have to take the interview where it leads, but where it's very helpful to have a form like that, because you make sure you don't forget something. If you've talked at length about one issue, you can go back and say, oh, I didn't ask him about, any thoughts of being persecuted, and you can go back and make sure you did that. And so that is how that form is typically used.
Thank you. Now, overall, based upon your clinical interview, based upon the testing that you performed and your work with Dr. Gray, what was your overall impressions and conclusions and answers to the question that you were asked to answer?
My conclusions as a neuropsychologist was that he had subtle dysfunction, as I've explained previously. My conclusions as in reviewing Dr. Gray's data along with talking with Dr. Gray and looking at those results was that there was evidence of mental illness.
Okay. Did that evidence of mental illness, in your opinion, include marked depressive symptoms, anxiety, and a proneness to psychoticism?
Yes.
How about obsessive compulsive behaviors?
Yes, though you'll have to ask Dr. Gray about that piece further. I can't remember what those I know he had a history of hair pulling. That might have been it.
Okay.
I can't remember right now.
But the others you recall?
Yes.
Did it appear that the information suggested a progressive development of psychiatric symptoms?
By the history we got, yes.
Okay. And again, you're limited by the amount of information you had. Fair
That's
to say?
right. The structure of our evaluation limited all the opinions I can provide, of course.
Did you come up with a kind of possible diagnostic suggestions, or what, a differential diagnosis, I guess?
Right. So possible diagnostic possibilities that we talked about and that we wrote in the report were, did he have a schizoaffective disorder? Was it schizophrenia with a depression? Or was there another mental, another psychiatric illness going on? We did not know. We were not purporting to diagnose him firmly. We just raised these as diagnostic possibilities.
And that makes me have a thought about, you said in your work, you care for folks that are sometimes with you for a long time at the hospital, for years at a time. Is
That's
that right?
correct, yes.
Did the diagnoses that those people receive, do they sometimes change a little bit over time? Can they be amended? Can the doctors think it might be one thing at a point in time, and then as things progress, they change a little bit or reformulate or solidify their opinions?
Yes. We have certainly some people come into our hospital and don't stay very long. We have others who are here for years and others who come and then they come back again. So we have test data and evaluations that go back many years. And in my work at the hospital, it's part of my job to look at old records. And so I see people, what their diagnosis is now, and then I see evaluations that were done at the earliest point of their hospital admission or their earliest entry into the mental health system at our facility. And at those early points, there is often, it's not uncommon to have a certain amount of disagreement among the psychiatrists or psychologists who are evaluating someone. And then over the years, the symptoms patterns become much more stable. There's a longer period of time to judge the significance of each symptom, and then a diagnosis is solidified over time that is much more consistent. So a long answer to a short question is that yes, at the early point of someone's entry into the mental health system, sometimes the diagnoses aren't all the exact same. They'll be on the same continuum, but slight differences.
Okay. And is part of what informs that honing of the diagnosis or whatever, as it were, ongoing, like testing, for example? Is it helpful to test somebody again at a later time, or to go do a clinical interview with them at a later time?
Well, what I've seen helpful at the hospital is just when the person is there and then they've been there day in and day out for months and years, the clinical staff have a lot of behavior observations that help solidify the diagnosis more than anything else.
Okay. And just to deal with that issue real quickly, the hospital staff that interacted with Mr. Holmes, were these really experienced folks that were chosen to do this?
Of course, the hospital wasn't about to put any new employee on, to be working with Mr. Holmes. Experienced staff were.
And were there specific people assigned to him when he was there that limited period of time?
Of course.
And did they make a lot of effort to interact with him?
I think they did. From what I saw, they tried to talk with him. There were 2 nurses there. When every time I got there, they had 2 nursing staff members with him, and he was watching movies and sitting and walking in the yard, I think, sometimes.
So he was, were there times that he interacted with them that you were aware of by reviewing their notes, by talking with them or laughing?
Well, I think sometimes he talked with them, yes. Again, it wasn't what I observed, because when I would get there, they would leave that room and they'd be behind the glass so they could see. They could still observe him, make sure he was safe, I was safe, we weren't having any problems, which we weren't. So I didn't observe them interacting with him, but I did read in their notes that they did.
Okay. And in your experience at the hospital there and with other mentally ill patients, does that mean that they're not mentally ill because they can interact with staff, or?
No, these are staff members who are trained to work with mentally ill people. So there are certainly people who are so very ill that they don't interact with anyone. But many people who truly have psychotic illnesses are able to, have exchange verbal pleasantries and interact in any number of ways throughout the day with staff members who are trained to work with them.
Okay. And you were talking about how diagnoses may change over time or may be slightly different at the beginning. You've reviewed the reports of the various psychiatrists in this case, you said before. In your opinion, is there a certain amount of congruence among what the doctors have diagnosed Mr. Holmes with?
Hey, would counsel please approach? right, the objection is sustained, but Mr. King, you may proceed as we discussed.
I could have one moment, Your Honor. One more question, Doctor. One more question, Doctor. Based upon your testing that you did in Colorado Mental Health Institute at Pueblo, were the possible diagnoses that you thought would be appropriate schizophrenia together with major depression, a mood disorder with psychotic features, or schizoaffective illness?
Yes, those are the diagnostic possibilities we raised.
Thank you, ma'am. I don't have any other questions.
All right, Mr. Brockler, do you have cross-examination? All right, you may proceed.
Good afternoon.
Good afternoon.
Doctor, I have some areas that I want to go into with you, but I want to start off by making sure that we understand the scope of what you were asked to do, as well as the scope of the opinion that you're giving us today.
Yes.
Okay. It would be fair to say that you were asked to provide a snapshot in time of the defendant, limited really to just August the 12th through the 15th of 2013.
That's fair to say.
You were not asked, nor are you capable, given the tests that have been provided, of going back to July 19th, 20th, or even before then of 2012.
And opining about his status at that time?
Correct.
Yes, I cannot do that.
Right. And the reason you are asked to do this very finite, circumscribed area of investigation was for Dr. Metzner, correct?
Correct.
And your understanding is that Dr. Metzner wanted a neuropsychologist like you are, correct?
Correct.
A board-certified forensic psychologist like you are, correct?
Correct.
To provide him with some information that he could incorporate into a much more detailed, much broader sanity evaluation of the defendant.
That is exactly correct.
And that's what you did with your information, correct?
Correct.
And your understanding is that Dr. Metzner incorporated all of your information and opinions and potential diagnoses and Dr. Gray's into his opinion, finding the defendant sane.
That is correct.
Now, there are some things I do want to talk to you about, though, about the testing. You went through a whole bunch of these tests, and then at the end, you said, and I don't want to overemphasize the word because you didn't, but you said, I found largely that his processes, if I'm using the right word, were intact, correct?
Correct.
And if there were any deficits at all, is that the right term, deficit?
Deficit.
Is subtle, and you said subtle with a special kind of subtle squared. Is that fair?
That's fair.
When you say subtle in that way, are you suggesting this is really pretty slight impairment?
In terms of his neuropsychological status, absolutely. These are subtle impairments in his neuropsychological status.
And not just subtle in terms of his status, but subtle in terms of his status considering other white male guys who have been in school 16 or 17 years. Is that right?
Correct.
Compared to regular person like me, regular person in the community, that average or slight impairment would look pretty daunting. That would blow me away.
Oh, maybe I didn't understand. Compared to other people in the community, stop me if I'm not answering what you're asking me, but if compared to other people in the community without that advanced level of education, his thinking skills would look pretty normal.
Pretty good. Mm-hmm. And so just a slight impairment.
Correct.
Now, there are things that you went through with Mr. King that talk about the different areas that some of these test can cover. And I want to make sure I understand this. You do not have a test that was administered here that is going to tell us whether it's for August of 2013 or 13 months before, whether or not that guy had the capacity to know right from wrong based on societal standards of morality. Is that right?
That is correct.
And while you cannot, based on these tests, tell us whether or not he had the capacity to form the intent to murder after deliberation or to act knowingly in setting up all these bombs in his apartment, there are some things here that suggest that he had the intellectual capacity to do those things. Is that correct?
Yes, his intellect was sufficient for those kinds of activities.
Now, there's one specific area I wanted to ask you about, and that is with regard to executive functions. Do you remember that?
I do.
What I recall you saying is that is like the highest order of what your human brain is asked to do fits into the executive functions. Is that correct?
Correct.
Is that the front part of your brain?
Right, the prefrontal cortex.
Okay. We'll pretend I know what cortex is. What does it mean?
It's the part of the brain. We're talking about the layer of cortex on the surface of the brain, our gray cells.
Okay. So is it this front area, like right behind my forehead sort of an
the
area?
cortex is over the whole brain, but we're talking about the prefrontal cortex would be right there.
Right in the front?
Yeah, in the front.
There is a favorite test you have for testing executive function.
There is.
And that favorite test is called the Wisconsin Card, some other letters, ST.
The Wisconsin card sorting test.
Card sorting test. Can you give us a little more description about that test?
So it's a test where it uses cards, of course, because that's in the title of the test. And he has to solve problems with these cards and adapt his problem-solving strategy based on information I give him. But I never tell him why or how to solve the problem, him or anyone else. You know, there's a very specific protocol you go through. And when someone is making a correct answer, you let them know they're correct. And when they're wrong, you let them know they're wrong, but you don't tell them why. And they have to figure it out through a whole series of trials on this test.
It sounds tough.
It can be frustrating, yes. When people have trouble, it can be very frustrating for them.
And his performance on that, 13 months after the alleged crime here, was above average.
Correct.
For his demographic, right?
Correct.
White, male, 16 to 17 years of education.
Right, and that test wouldn't be norm for ethnicity, but definitely people his age with his level of education, yes.
And that area, that executive function, that test, and that test itself, tests our ability to reason, correct?
Yes.
To problem solve.
Yes.
The way you've described it sounds like it requires us to be able to shift on the fly under changing circumstances.
That would be fair to say.
Processing information.
Right.
And quickly.
Well, it's not timed, but certainly they need to do it. I can't say I don't have a stopwatch. That's not the way the test is, but they definitely have to process information and shift in context. They can't. I'm not giving them, like come back tomorrow and tell me how to do it. Right.
And that's the test that the defendant performed above average for his demographic.
He did.
There was a test that you talked about that he seemed slightly impaired on, and there was something I wanted to clarify with that. Remember that PEG board test you talked about with the different things he has to put in there?
Are you talking about the tactile performance test where he was the blindfolded one, or was it the grooved pegboard where he's the grooved pegboard?
It had the word PEG in it, so grooved pegboard one.
Okay.
That one could be affected to some extent by cogentin.
Right. Well, cogentin, not by the cogentin, but people who are prescribed antipsychotic medications sometimes are prescribed a medication. And I'm speaking as a psychologist. I am not a psychiatrist, and I am not licensed to prescribe medications, but I need to be generally aware of these issues in my work. But I want to clarify the limits of my expertise in this area. But people who have a psychotic disorder, or people who are prescribed an antipsychotic, are sometimes prescribed a medication called cogentin because it helps avert motor side effects that can come about, meaning they have shaking of their hands, they have trouble moving their hands, etc. So the cogentin is usually given by a psychiatrist to counteract those motor problems.
Okay.
Okay, I'm sorry if I answered more than you wanted.
No, ma'am. No, and Doctor, I appreciate the disclaimer part. Nobody wants to testify to stuff they're not qualified to, and I appreciate that. Thank you.
That's right.
Something I wanted to get cleared up with you, though, was you had said initially that the defendant told you that he had no audio or audible hallucinations, and then Dr. Gray had pointed out that some of the answers on some of the tests he did, the MMPI-2 and the PII, fair?
Fair,
Indicated something different, and then he gave more information, correct?
Correct. Yeah, I can't remember if Dr. Gray read him the item or just asked him about it, but he probed that.
And then you also indicated to Mr. King that the defendant, there were times where you felt like he was not giving you a lot of information.
Correct.
Now, here's what confuses me. You said that on all the validity testing and malingering testing, he came out totally fine. Doesn't that mean that he'll always give you accurate, honest, full, and fair information during interviews?
No, they're not the same thing. So the validity testing I did, and I'm speaking now to mine, was to do with his thinking skills. Was he going to fake memory problems? Was he going to pretend he couldn't problem solve, pretend he couldn't pay attention when he could? His validity tests were clean. He was giving really reasonable effort, good effort on all my tests, and then that was what those validity tests were limited to, the thinking skills tests.
So those tests have nothing to do with whether or not when he's answering your questions, Dr. Gray's questions, or any of the mental health professional questions in here, if he's being honest, candid, forthright, accurate, none of those things.
Right. Well, in adding to that, there were tests that Dr. Gray gave that had validity indicators that would address that, but mine, not really. I mean, it would just be a general description of how he was doing on thinking skills tests.
And you've already told us that's not none of these things are foolproof tests.
Oh, of course not. No test is foolproof.
I'm going through my stickies here.
Of course.
A couple other things. You ended up speaking with Mr. King about the actual interview that you did with the defendant. Do you recall that?
I do.
There are some observations that you made, and these observations you said were psychologically important to you.
Yes.
One of those things that you touched on was grooming, correct?
Correct.
And it is one of the hallmark signs, although it's not required for everyone, that someone who has a certain type of mental illness, as you said, kind of gives up on themselves, stops caring about their personal hygiene, stops caring about how they look, how they appear, all that stuff, right?
Right. That can absolutely happen.
And that did not happen with the defendant, correct?
Not when we saw him.
And you have no idea whether or not that was consistent from well before you saw him.
I don't.
Also, his speech patterns and his manner of answering, you've talked about that, right?
Right.
And that could tell you some things about potentially some sort of mental illness, potentially, yes?
It could.
And one of those potential mental illnesses that might be implicated by that could be things like schizotypal personality disorder.
Certainly, that could.
Any of the things you referenced in your report, correct?
Could as well.
In fact, in your potential diagnoses, one of the things that you indicated was not just that you thought it could be, I think it was schizoaffective or schizophrenia with a major mood disorder, but one of the things you said is, look, this is a bit complicated, because this could be a personality-driven issue, right?
We brought up personality disorders, absolutely.
In fact, one of the other things that's referenced in there is the potential, the whiff of narcissism. Do you remember that?
I do.
And you, to be fair, it's not a criticism, you don't know if the way the defendant answered you and dealt with you was the way he'd been answering and dealing with people for years.
I can't say that I do.
There were some specific questions that you asked him, and one of them was, hey, what are you doing for your free time? Remember that?
I do.
And is that just an icebreaker, or is there some reason to try to find out what he's doing?
No, I want to know what people are doing when I evaluate them, when I test them, if they're going to give a testing performance that is inconsistent with how they're occupying themselves when they're in their downtime.
And he told you that he was watching movies,
Correct.
And reading The Hobbit.
Correct.
Now, one of the things that may have come up, I can't remember, with Mr. King is the movie selection at CMHIP is a bit limited.
Yes, by design, it's quite limited.
Yeah, only G-rated movies, correct?
Right. I think there might have been a PG one in there too. Whoa, I know, but yeah, they limit those. They certainly don't, go to Redbox and get any old thing. There's certain things that they don't allow.
And you understand from your questioning with him that prior to being incarcerated, he'd pass the time by playing video games and watching movies.
Correct.
Doesn't have access to video games anymore, right?
No.
Nothing horribly inconsistent about that then.
No.
You talked to him about he did well in school.
He did,
He was able to provide you with some information about that, correct?
correct.
You talked to him about his girlfriend, and that's when he kind of clammed up on you a bit, right?
He did,
He did not want to answer more questions about his girlfriend.
right.
You asked him about his past psychiatric history separate from what you'd been provided in any sort of materials. Do you recall that?
We did.
One of the things that he tells you when you ask him about whatever treatment he had at age 8 is, I don't recall that. Is that right?
That's right.
He didn't tell you that I was taken to treatment because I was screaming, but I wouldn't talk. He didn't tell you that?
No, can I look at my report?
Oh, yes, ma'am.
Thank
Please
you.
do.
Let me
Doctor.
just
Sorry,
double-
doctor.
No,
Yes.
that's all right. Let me just double check this here.
Yep.
Oh, yes, I just wanted to make sure that that was correct, that he said he did not recall treatment at age 8, and that was correct. He told us he didn't remember that.
So part of that not remembering, my guess is he didn't tell you about any time where he'd been taken to treatment because he had barricaded himself in a room.
No.
Judge, I'm going to object. He apparently said he didn't remember, so he couldn't have told her anything about it.
Overruled.
Also that he didn't say that he had been taken to treatment at any time because he had punched or hit his sister.
No, he didn't say that.
You said that he told you he was depressed slightly. Is that right?
Let me
Yeah,
check his
it-
wording, but, yeah.
All I ask, doctor, is that when you do that, you just say for this court reporter, write down, I'm looking at my report. That's all.
Of course, yes, I'm looking at my report. He described his mood as slightly depressed. Yes.
And was that consistent with what you observed from him?
He described his mood as slightly depressed. Yes.
And was that consistent with what you observed from him?
The withdrawn nature of his interpersonal interactions, I didn't know what exactly that was due to. If it was due to depression, it would be more than slightly depressed. If it was due to personality factors that are long-standing, then, yeah, that would be consistent.
You specifically asked him about mania. Do you recall that?
I do.
In fact, you didn't just ask him about mania. There are specific things in your notes about asking about things like spending sprees.
Correct.
He denied any of it.
That's right.
The visual hallucinations part, to be clear, and I know you were trying to distinguish between just before the Risperdal. Am I saying that right? Is it Risperdal or
It's risperidone or Risperdal. Risperidone is the generic and Risperdal is the brand name.
Thank you. Risperdal is to try to figure out if the Risperdal is addressing, I imagine, whatever's going on. Is that fair?
Right. Did he notice a change?
One of the things that he told you was that he had seen shadows moving around right before he got on the Risperdal.
That's what he said.
It's your understanding that that was a reference to November, correct?
Correct.
He never tells you about any other objects, things, shadows that he saw?
No, he didn't.
Doesn't ever say anything about shadows juggling heads or swords or guns or nothing like that?
He didn't, and just to also answer fully, we didn't probe it further.
Sure.
He didn't bring it up, no.
He didn't offer that?
No.
Okay. One of the other things that you mentioned on direct was you specifically asked him, hey, do you have some sort of special mission in life?
I did.
And he says, nope.
He said no.
Denied any thought insertion?
Correct.
Denied any persecutory delusions?
Correct.
Can I have 1 second, please? Yeah, I'm sorry. I'm acting like everyone knows the words I'm asking you.
Okay.
Just tell us briefly, if you could, what's thought insertion?
That's when, for example, I believe that you are inserting ideas into my mind against my will.
How about persecutory delusion?
I believe you're out to get me. I believe, the CIA has got me pegged, and you're their agent, and you're going to do me harm. That's an example of it.
The only time he says he hears voices is when he was at Denver Health, right?
Right, and we were limiting our questioning to that area.
Got
Right.
that.
Yep.
Got that.
Yep.
Thank you. He never gives you any indication of delusional thinking in the area of something called human capital.
No, he did not.
Nothing about feeling homicidal towards people.
No, there was one point.
Yep.
He didn't talk to us about that, the homicidal piece. He didn't talk with us about that. I do have a note, and I was going to look in my report about the reduced homicidal thinking, but he didn't talk ever with us about human capital or...
And my sense of it, too, is given what you've told us, is that there's like a lot more information that you were provided in terms of documents than what you got out of him. Fair?
Fair.
We've got those witnesses, and what I don't want to do is end up making you testify about what someone else did or wrote. So
Of course.
he
yes.
never tells you anything like that.
I don't think so, no.
Did you, in terms of the records that you reviewed, you said that since July of 2012 you had reviewed mental health records from the Arapahoe County Sheriff's Office. You recall that?
We did.
Did you review any of the kites? And if I use that term and you don't know what that means, would you tell me?
Oh, I know what that means.
Okay. And we'll just say on the record, kites are when inmates request things.
That's right.
Did you review any of those?
I didn't see any kites, no.
How about any other behavioral logs outside of the mental health stuff? Observations that deputies made about what he was doing day in, day out?
I did not. I think it was just the mental health records.
So you don't know how uneventful or boring those 4 months leading up to the November incident were?
I don't.
Okay, let's do that. May I have one moment, Your Honor?
Yes.
Doctor, you have no opinion to offer us on anything related to sanity surrounding July 19th or 20th, 2012. Fair?
Fair.
Nothing further, Your Honor.
All right, Mr. King, do you have any redirect?
Just one question or two.
All right.
You were asked, ma'am, about Mr. Holmes being cognitively intact, basically, and his deficits being small.
Yes.
That's true of his cognitive function. That's what your testing related to. Is that right?
That's right.
Suffice it to say that somebody who may be intact cognitively, but who is acting pursuant to psychotic delusions, for example, their thinking would be, although they're cognitively able to think, that thinking could be impaired by the psychosis for certain.
That is an important distinction, and that is absolutely true. Even though someone's intellect, reasoning, attention, memory, and so forth can be intact, if they are psychotic, their thinking, their functional thinking will be distorted.
Regardless of how intelligent they are.
That's right. Even intelligent people can become mentally ill.
And you were asked about the validity testing that you did, and what you said was that validity testing pertained to the cognitive test that you gave. Is that right?
That's right.
And counsel asked you, that wouldn't address things like whether Mr. Holmes was being honest or candid or forthcoming regarding his mental illness. Do you remember that line?
I do.
And you said that there were tests that Dr. Gray administered that addressed those issues. Is that right?
That's correct.
And the results of those tests were that Mr. Holmes was not malingering
That is
any
correct.
of his psychiatric symptoms. Is that right?
That is right.
Thank you. I don't have any other questions.
All right, Mr. Brockler, do you have any recross?
Thank you. I want to kind of ask the inverse of something Mr. King asked you. Despite the fact that someone has a mental illness, regardless of what it is, that is not a preclusion to their ability to plan and carry out the attempted murder of dozens after intending to do so, deliberating to do so, correct?
Correct.
Object to the form of the question, Judge.
Overruled.
I'm sorry, what was your answer, Doctor?
I said that's correct. That would.
Wait, hold on a second. Let me just see. Hold on. Yeah, overruled.
Could you repeat the question? I'm sorry.
Yes.
I think she
Oh,
answered.
did I answer enough?
You
Okay.
did.
Thank you, Your Honor.
Another question with that, just the fact that someone is mentally ill and certainly 13 months later showing any sort of psychoticism or whatever we think it is, does not preclude them from having knowingly planted or developed bombs potentially in their apartment to be used as a diversion or to hurt others.
No, that would not preclude that.
There's nothing about mental illness, at least as far as we see in this case, that would keep somebody 13 months before from having the capacity to know right from wrong based on societal standards of morality.
Objection beyond the scope of her expertise.
Sustained.
I just want to ask this one last question to follow up. Your conclusion was that the scores are within normal limits and are not reflective of any basic impairment in the ability to pay attention, reason, use language, remember, or problem solve.
Objection asked and answered.
Overruled.
Correct.
Thank you, Your Honor.
All right. The jury may have, no, the jury does not appear to have any questions for this witness, so may this witness be released from our subpoena. Mr. King?
Yes, Your Honor.
Is there any objection, Mr. Brockler?
No, sir.
Okay. Doctor, thank you.
Thank you, Your Honor.
Call your next witness, please.
Just, can I have just a moment?
Yes.
Is the court considering taking a recess?
We could. It makes sense. Do you want me to, should we do that?
If you could do it now, I could make a decision on how I want to proceed.
All right, great. Let's do that. All right, folks, let's go ahead and take our afternoon break right now. Please keep in mind all my admonishments. They apply during the break. I'll see you back here in about 20 minutes, all right? A little bit before 3:30. Thank you. The record should reflect that the jury has exited the courtroom. Everyone may be seated. Mr. King, if you need more than the 20 minutes, let my staff know, and we'll take longer than that, okay?
I think that'd be fine, Judge. I misspoke before. Can we please keep Dr. Manguso under subpoena?
Okay. All right. Is Dr. Manguso still here? All right. Doctor, you're free to go for now, but you're subject to being called back, okay?
Yes, Your Honor.
All right. Thank you. All right. So we'll be on break? All right. Thank you. I'll see you in about 20. The court will be in recess.